All right, so we're diving into digital joint dislocations this time.
Yeah, focusing on the MP and PIP joints, those are the ones that'll really trip you up on the FRCS exam.
Yeah, absolutely got to have those nailed down.
Exactly, and we're going straight to the source with this, drawing from the latest surgical expertise to make sure you're completely prepared.
So no fluff, just the need-to-know stuff, anatomy classification, how to evaluate these injuries, and the key treatment principles.
That's the plan, ready to jump in.
Let's do it. So first things first, when you're facing a digital joint dislocation in the exam or in real life, what's the absolute must-do?
Structured clinical assessment always. It's all about evaluating stability, both active and passive.
Okay, active versus passive. Break that down for me.
Active stability is all about the patient, can they move the joint through its full range of motion? If they can, that's a good sign. Often means the stabilizing structures are intact.
Makes sense. So if there's instability with active motion, that's a big red flag.
Huge red flag. Now, passive stability, that's where you come in as the examiner you're feeling for any laxity.
So we're talking about stressing the joint laterally in full extension, and then again at 30 degrees of flexion.
Precisely. That gives you a good idea about the collateral ligaments. We also need to check for any dorsal and volar instability.
Got it. And don't forget to compare everything to the uninjured side.
Absolutely essential. You got to account for those individual variations. Everyone's a little different.
Okay, so we've done our exam. What about imaging?
At least 3 views are a must: AP lateral and oblique.
And always include the joints above and below the injury, right?
Can't stress that enough, gives you the full picture. Now remember, dislocations are always named by the position of the distal bone in relation to the proximal bone.
Got it. So say the distal phalanx is sitting dorsal to the middle phalanx.
Yeah.
That's a dorsal dislocation.
You got it. Now, a quick word on ligament injuries. You're going to see this grading system a lot. Grade, I sprain. That's stable, just some microscopic tears.
Grade 2.
Grade 2, there's some increased laxity, but the ligament is still intact.
And grade 3.
Complete tear, gross instability. You're going to need to change your management based on this grade.
All right, makes sense. So let's dive into the finger MP joint.
The MP joint, yeah. This is where things get interesting anatomically.
And the anatomy is key to really understanding these injuries.
Absolutely. The star of the show here is the ligament box complex.
Okay, so more than just the ligaments themselves.
Way more. It's this intricate interplay of the ligaments, the flexor and extensor tendons, the sagittal bands, even the intrinsic muscles, all working together for that protection.
That's a lot of players.
It is. And we can't forget the volar plate.
That's the floor of the joint, right?
Exactly. It provides that essential volar support.
Yeah.
And if you look at figure 6.6 tone 1, you'll see the intervolar plate ligament.
Connecting those ligament boxes across the metacarpals.
You got it, which further strengthens that volar plate. Now, here's a concept you really need to grasp for the exam, the CAM effect.
The CAM effect. I've heard of that, but always a good refresher.
Think about the shape of the metacarpal head. It's wider on the volar side. As the MP joint flexes those collateral ligaments, they run along the sides, get pulled tight because of that wider volar part.
So that tightening provides a lot of lateral stability and flexion.
Exactly, but when the joint extends, those ligaments slacken, allowing for abduction and adduction.
So understanding that mechanic helps us predict injury patterns and make sense of those stability tests.
Absolutely spot on. Now let's talk about dorsal MP joint dislocations.
These are the ones you see with like a fallen and outstretched hand, right?
Classic mechanism, forced hyperextension, and they're most common in the index and small fingers.
Here's a little exam tip. A dislocation of a central digit MP joint never happens in isolation. One of the border digits has to be dislocated too.
Absolutely got to remember that. Now, these dorsal MP dislocations, they're classified as either simple or complex subluxations.
So simple first.
A simple MP subluxation, it's incomplete. The proximal phalanx gets locked in 60 to 80 degrees of hyperextension.
Ours sounds painful.
It is. But the reduction technique is pretty straightforward. Flex the wrist to relax those flexors. Then gently increase the hyperextension for a moment.
Okay, and then?
Then you apply direct dorsal pressure on the base of the proximal phalanx while you gradually flex the MP joint.
Simple enough for a simple subluxation.
Yeah.
What about the complex ones?
Complex MP subluxation, that's a whole different ballgame. This one's complete and irreducible.
Meaning?
You can't just pop it back in place. The metacarpal head, it goes volarly and gets trapped between the lumbrical and flexor tendons. The volar plate often gets stuck in the joint too.
So what's the catch?
The flexor tendon sheath, it stays attached to the volar plate and it's tight. the distal finger joints, they're often flexed because of this whole tendon lumbrical situation.
Making closed reduction impossible.
Exactly. You need open reduction, and usually you have to release the A1 pulley to take the pressure off.
Post-op immobilization.
30 degrees of flexion for 2 weeks. Then active range of motion with a 10-degree dorsal blocking splint for another 2 weeks.
All right, so open reduction for the complex cases. The volar MP joint dislocations, those are rare, right?
Thankfully, yes.
Uh-huh.
And usually closed reduction does the trick. Open reduction is there if you need it.
Okay, good to know. Now, what about collateral ligament ruptures of the MP joint?
Isolated UCL ruptures in the fingers, super rare.
But isolated RCL ruptures.
Those are more common, especially in our athlete population.
So picture this, a force causing ulnar deviation to a flexed MP joint.
Often affects the ulnar 3 digits. And here's the thing. These injuries can be sneaky. Sometimes they present late with just swelling and some dysfunction.
So how do we catch them?
On exam, you'll find tenderness on the radial side of the joint pain with passive flexion of the MP joint and instability when you stress the finger ulnarly.
And how do we manage an RCL rupture?
First line is immobilization MP joint in 30 degrees of flexion for 3 weeks. Then you reevaluate the stability. If there's still a lot of laxity, buddy taping for a couple more weeks can help.
And if all that fails?
Surgery, but that's usually reserved for cases where the instability or pain sticks around for more than 6 weeks despite the non-operative approach.
Okay, on to the thumb MP joint now.
The thumb, yeah, it's a unique joint. That range of motion is something else.
Flexion and extension are primary, of course,
Mm-hmm.
but then you've got abduction, adduction, and even pronation and supination.
Exactly, a lot going on there. And the collateral ligaments are a bit different too. They have a proper and an accessory component.
With that accessory part inserting onto the sesamoid bones within the volar plate.
You got it.
Yeah.
Then you have the fine arm muscles providing dynamic support.
And on the volar side?
The volar plate itself and the thenar intrinsic muscles attaching to the sesamoids, they're key for stability. Now let's talk about acute UCL injury of the thumb MP joint.
Otherwise known as skier's thumb.
Exactly, 10 times more common than RCL injuries in the thumb usually happens from a forced radial deviation.
Like falling onto an abducted thumb while holding a ski pole?
Classic scenario. And remember, distal UCL tears are way more common than proximal ones.
Also got to watch out for avulsion fractures.
Absolutely. If it's a small avulsion fracture and it doesn't involve the joint surface, a cast usually does the trick.
But if that bony fragment is bigger, say more than 2 millimeters of displacement.
Then you're looking at CRPP or ORF.
Now for the big one, the Steiner lesion.
The Steiner lesion. This one's important. It only happens with a complete tear of the UCL.
Okay, so walk me through it.
The adductor aponeurosis, that's a tendon-like structure of the adductor pollicis muscle, it gets in the way.
It's in the way of what?
It gets between the ruptured UCL and its insertion on the proximal phalanx basically blocks the ligament from healing properly.
So non-operative management is out of the question.
With a Steiner lesion, surgery is a must. Now, for acute UCL tears, the treatment depends on whether it's partial or complete.
Partial tears, how do we handle those?
Usually a cast for 4 weeks, then a removable splint for another 2 weeks, focusing on active range of motion exercises.
Of complete tears.
Those often need surgery, especially if there's a Steiner lesion or a displaced fracture. For avulsion fractures, you might use bone anchors to reattach the ligament.
What about central ligament tears?
Direct suture repair is common there. Post-op thumb spike to cast for 4 weeks, then a splint for 2 weeks, again, with an early emphasis on those active range of motion exercises.
All right, now what about when these UCL injuries become chronic?
That's when we talk about gamekeeper's thumb.
Gamekeeper's thumb, so that's chronic UCL injury. Got it.
It can develop from an untreated acute tear, a missed Steiner lesion, or just a gradual weakening over time.
What are the telltale signs?
Chronic pain around the thumb, MP joint swelling weakness, anything lasting more than 6 weeks. You need x-rays to rule out osteoarthritis before you even think about ligament reconstruction.
And if it is chronic UCL instability, what's the treatment?
Surgical reconstruction using a free tendon graft.
Where do those grafts usually come from?
Palmaris longus flexor carpi radialis abductor, pollicis longus plantaris tendon, sometimes even a toe extensor tendon.
So during the surgery, any scar tissue or remnants of the original UCL are removed and the graft is put in place.
That's the gist of it. Post-op thumb spica cast for 6 weeks, then a splint for 2 weeks, and gradually increase those active range of motion exercises.
Got it. And if there's chronic volar subluxation of the MP joint?
You might need to temporarily pin the joint during the reconstruction.
Okay, good to know. Now on to RCL injuries of the thumb MP joints.
These are less common than UCL injuries, usually from a forced adduction or a twisting force on a flexed MP joint.
Interesting fact, There's no stentor lesion equivalent on the radial side.
Nope. And these RCL tears can be either proximal or distal.
How do those differ in terms of management?
Partial tears, you treat them non-operatively like partial UCL injuries. Even isolated complete RCL tears can sometimes be managed without surgery.
Well, when do we operate?
When there's volar subluxation of the MP joint along with that complete RCL tear, then you'd go for a free tendon graft similar to the UCL reconstruction.
Makes sense. Now, last thing on the thumb MP joint dorsal dislocations,
These are more common than volar dislocations, usually from hyperextension.
which leads to a rupture of the volar plate and often a partial tear of one or both collateral ligaments.
Exactly. Luckily, most dorsal dislocations can be reduced without surgery.
So, after reduction, what do we do?
Immobilize in about 20 degrees of flexion for 2 weeks. Then start active flexion exercises with a 20-degree dorsal blocking split to prevent redislocation.
If there's been a significant collateral ligament injury, though, might need a longer immobilization period, right?
Yep, up to 4 weeks. Now here's a crucial exam tip. If you can't reduce a dorsal dislocation of the thumb MP joint with closed methods, think entrapment.
Entrapment of.
The volar plate, a sesamoid bone, or the FPL tendon inside the joint, you'll need open reduction for that.
Okay, that's a lot to remember about the MP joints. Let's move on to the PIP joint now.
The PIP joint, yeah, another one where dislocations are super common.
Most common ligamentous injury in the hand.
Got it. And the anatomy is crucial here too. The PIP joint typically has a range of motion of about 100 to 110 degrees.
And the lateral collateral ligaments, those have a proper component that inserts onto the middle phalanx and an accessory component that blends with the volar plate.
Exactly. And in most PIP dislocations, these ligaments avulse proximally from the proximal phalanx.
Now, the volar plate, what's its main job?
Prevents hyperextension, but it also allows for full flexion and acts as a secondary stabilizer against lateral deviation.
Especially if those collateral ligaments are injured.
That's right.
Yeah.
Just like the MP joint, the ligament box complex figure 662 shows it really well, provides overall stability.
So for a dislocation to happen, that complex has to be disrupted in at least 2 planes.
Precisely. Now, dorsal dislocations of the PIP joint, these are frequent, often from hyperextension and longitudinal compression.
And a distal avulsion of the volar plate from the middle phalanx that's seen in about 80% of these injuries.
Yep. Gotta watch out for a proximal avulsion of the volar plate, though.
Why is that?
It can trap an osteochondral fragment in the joint, makes the dislocation irreducible, and you'll need open reduction.
Okay, good to know. Now let's talk about classifying these dorsal PIP dislocations.
Right, because the classification guides the treatment. We have type I gray, the hyperextension injuries.
Resulting in a partial or complete avulsion of the volar plate.
The middle phalanx usually locks in 70 to 80 degrees of hyperextension, but there's usually still some contact between the bones.
Okay, then you have type 2.
Complete dorsal dislocations, complete avulsion of the volar plate, and a significant split in one or both collateral ligaments.
So no contact between the bones at all.
And then there's type 3, the fracture dislocations.
An avulsion fracture of the volar aspect of the base of the middle phalanx, along with the volar plate.
Exactly. And these type 3 injuries are further divided into stable and unstable based on the size of that fracture fragment.
So let's break down those treatment strategies for acute PIP dislocations.
For type, all you need is closed reduction and immobilization in 20 to 30 degrees of flexion for a week.
Important to avoid prolonged immobilization here, right?
Absolutely don't want to risk edema and stiffness, which can linger for a while.
What about type 2 dislocations?
Those need a bit longer immobilization period, usually 2 to 3 weeks, still in the 20 to 30 degrees of flexion.
Okay, and stable type 3 fracture dislocations.
Closed reduction and a dorsal blocking splint at 20 to 30 degrees of flexion for 3 weeks.
Extension block splinting can be really effective here, right?
Definitely. You start by figuring out the angle where the joint wants to redislocate and block extension beyond that point.
Then gradually reduce the flexion angle of the block by 10 to 15 degrees each week.
After 3 weeks, you ditch the splint and start range of motion exercises.
All right, so those are the more straightforward ones. What about the unstable type 3 fracture dislocations?
Those are the tough ones. Dynamic skeletal traction can be helpful for committed fractures with lots of little fragments.
When do we consider ORF?
For larger volar fragments, you want to preserve the volar plate insertion if possible, might need K-wires or small lag screws.
What about cases where ORF isn't an option?
Volar plate arthroplasty can be an option, but it has a higher risk of redislocation.
If you do go with volar plate arthroplasty, what's the post-op protocol?
Immobilize for 3 weeks, then unrestricted active flexion with a dorsal blocking splint for 1 to 3 more weeks to limit extension.
Best to do this within 6 weeks of the injury, right?
Ideally, yes. Now, there's another option for those really tricky cases, hemiarthroplasty.
Okay, so walk me through that one.
You take an osteochondral graft from the dorsum of the hemi bone and fix it to the defect at the base of the middle phalanx.
Early motion is key here, right?
Absolutely, within 3 to 5 days post-op. Reported outcomes look pretty good, average range of motion around 87 degrees and a high union rate.
But it's a demanding procedure.
Very technically demanding, usually reserved for cases with more than 50% of the articular surface involved.
Okay, a lot of options for those unstable type 3 injuries.
Yeah.
Now, what about chronic PIP subluxation?
Right, often from an untreated type I hyperextension injury leading to that swan neck deformity.
With those lateral bands snapping volarly with PIP flexion causing pain.
Exactly. You've got to differentiate a true volar plate injury from an extensor imbalance, though.
How do we do that?
Stabilize the PIP joint in extension and then check active DIP joint extension. If DIP extension is normal, it points to the volar plate.
And how do we repair chronic volar plate insufficiency?
FDS tenodesis, or the sublimus sling, is a common technique.
Explain that one to me.
You pass a slip of the flexor digitorum superficialis tendon, usually the radial one, through the proximal phalanx, and anchor it to the periosteum on the palmar side at about 5 degrees of PIP flexion.
Post-op.
Dorsal blocking splint to limit extension and immediate active flexion exercises. Unrestricted motion is usually allowed after 6 weeks.
Got it. Now on to lateral dislocations of the PIP joint.
Usually a rupture of one of the collateral ligaments plus a partial avulsion of the volar plate.
After reduction, we need to check stability, right?
Absolutely. If there's more than 20 degrees of lateral deformity with stress, that means a complete collateral disruption and injury to those secondary stabilizers.
Most of these can be managed non-operatively, though, right?
Yes, reduction and buddy taping usually does the trick, encourage early range of motion.
When do we consider surgery?
For subacute or chronic instability and persistent dysfunction.
Okay, last but not least, volar dislocations of the PIP joint.
These are less common, but we can classify them into a few types: non-rotatory dislocations, often with the central slip tear, rotatory subluxations, and volar fracture dislocation.
What about those non-rotatory ones?
Those are easy to reduce, usually just gentle traction. Then you splint in full extension for 4 to 6 weeks to let that central slip heal.
What about rotatory volar dislocations?
Most of those can be reduced without surgery too. Gentle traction with the MP and PIP joints flexed, then some gentle rotation to disengage.
After reduction?
Test that active range of motion. If they can't fully extend, actively immobilize in full extension for 6 weeks.
What about those volar fracture dislocations?
You might need CRPP or ORF depending on the size and displacement of that dorsal fracture fragment.
Got it. Now, one last thing to consider, collateral ligament fibrosis.
Ah, yes. A potential late complication of PIP dislocations usually develops over 10 to 12 months.
Can lead to stiffness and loss of motion.
Yep. Early and appropriate rehab after a stable reduction is key to minimizing that risk.
Sometimes a short course of low-dose prednisone can help too.
That's right. Tapered over 4 weeks can help with the edema and improve range of motion.
What about surgery?
You can consider surgical excision of the fibrotic tissue for a PIP joint contracture release if the range of motion is less than 60 degrees despite rehab, and it's really impacting the patient's quality of life.
So usually you'd excise both collateral ligaments but preserve those lateral bands.
Exactly. Got to have full passive range of motion before you even think about doing this, though.
To make sure there's potential for active movement after the release?
Spot on. All right, we've covered a lot. Let's quickly touch on the DIP joint and the thumb IP joint.
Anatomically similar to the PIP joint, but dislocations are less common.
Much less common thanks to the support from those flexor and extensor tendons.
When they do happen, though, usually dorsal or lateral dislocations.
Most can be treated with closed reduction and a dorsal splint in slight flexion for 2 to 3 weeks.
Irreducible dislocations are rare, but usually from a trapped volar plate.
In those cases, you'll need open reduction.
Dorsal fracture dislocations of these joints. What's the key there?
If that volar fragment is still attached to the FDP tendon in the finger or the FPL tendon in the thumb and it's not too displaced, closed reduction and splinting is often enough.
But if the FDP or FPL tendon is avulsed,
then you'll likely need surgery to restore function and stability.
Volar plate arthroplasty is another option for unstable fracture dislocations.
It is, especially when closed reduction and other methods have failed.
All right, that was a whirlwind tour of digital joint dislocations. Any final words of wisdom for our listeners prepping for the FRCS exam?
Absolutely. Know your classifications cold. Remember that CAM effect at the MP joint Steiner lesions always need surgery.
PIP joint dislocations, super common, and you need a disruption in at least 2 planes of that ligament box for dislocation to occur.
Those unstable type 3 PIP fracture dislocations, those are tricky. Know your surgical options.
And don't forget to differentiate between volar plate injuries and extensor imbalances when you're evaluating those chronic PIP subluxations.
Collateral ligament fibrosis is another potential complication. After PIP dislocations, early rehab is key.
It all comes back to the anatomy and biomechanics, right?
Absolutely. Got to understand the basics to diagnose and treat these injuries effectively, both on the exam and in your future practice.
So listeners, hit the books, review these concepts and those surgical techniques. Now, for a little something to ponder before we sign off, think about those unstable type 3 PIP fracture dislocations. What factors would really guide your decision between ORI-Ceph volar plate arthroplasty and hemiamate arthroplasty in a young active patient?
Lots to consider there.
That's it for today's deep dive. Thanks for joining us.
It's been a pleasure.